All right. All right, we're going to go ahead and get started on this session. And I felt a little claustrophobic this morning doing the first session at the podium. I have to move. I'm married to a Frenchman, and so they move their hands a lot. And then I just picked up that habit in our 17 years of marriage. It works. Anyway, so in this session, this is the one that Julie kind of talked up a lot. I hope I live up to expectations. But we're going to dive into policy, and we're going to dive into the chart audits. And at this point in time is usually when I see the eyes glaze over and everybody kind of tunes me out. I am thankful this session is before lunch and not after lunch, because I think it would be a very different topic. But my goal is to hopefully streamline your policies, because some of you all have like binders, and I mean binders of policy after policy that have not been cleaned out, rooted through, removed in 20 years. And so my goal is to help you know what has to stay in your policies because of compliance requirements. What's good recommended standard practice to have in your policy, because it's things that we've got feedback from surveyors over the time of working on this development of documentation. And then how do I know if I can remove a policy? Now, one thing I did notice is Julie's slide gave the date of when the COVID vaccine mandate was going to be removed from the law. I was like, oh, I actually haven't checked the ECFR to see if it's been updated. It is no longer in the law. It has officially been removed. Even on the ECFR 491.8D, it's officially out of the law. So I wanted to just make that mention. It's not just that the surveyors have been told not to measure it. It is officially out of the law for the RHC. Now, one of the things we are going to cover is if the policy says it, you still have to do it. Okay, so I'll give you some recommendations as we go through this conversation of being able to answer these big questions. What do I have to have? And how do I answer the question for the program evaluation? Am I following policy? Those are the two questions I really hope to answer. And through that, one of the topics of how to prove we're following policy is through those chart audits, both the collaborative and the administrative. We're going to dive into the detail of what each of those uniquely have to have within them and how to accomplish them at your position. I need to get this thing alive again. So let's do this.
Yeah.
Pause, please.
Sorry about that.
Oh, I think I know what it is. Oh, right here.
No, I can hear you.
Can you hear me?
Okay, I was gonna try talking again.
Are we all good? Can you hear me outside of talking to you?
People online saying yes.
Mm. That's on too well. That's probably why.
We need to come back to the podium.
No,
I-
I think the podium mic was on.
Are we all good?
You're all good?
All right, so I apologize to those online. Thankfully, the slides are going to be available. And so we'll make sure that we get through all of the required information. Essentially, the goal for today is to figure out how do we streamline policies? How do we know if we're following policies? What do I have to have? All right. Now, 491.11, one of the things that we do find when we're reviewing program evaluation reports for a facility, they don't actually address the question that's in 491.11 about is the clinic following policy? We don't see that question actually being answered. So there is a way to do this. There is a way to prove that your clinic is following policy. We would recommend a mock survey to make sure that you're following what you say you're going to do in your physical plant. We would recommend a chart audit review, which is required for 491.11 anyway, regarding the closed and open records that you're following your time frame for that. And the collaborative review also helps us meet that objective of being able to prove what we put in policy is what we're actually doing. So I have this statement, hopefully. We will get this, we will work it all out, and it will be wonderful. Because Julie really talked me up. Document what you do and do what you document. How many have heard this term before? It has been a famous saying of my predecessor, Ralph Belknap. She said this nonstop, right? How many of you know her? Okay, she's my mom, just so you know. Anyway, I talk like her, I move like her, I can't deny. But document what you do and do what you document. But some of your policies put you into a box. You have written them so specific that you cannot meet the measurement that you set forth for yourself. Or they were written 10 years ago, and we're not sure what they say. So there are going to be some recommendations through this of how to expand and give you some space within your policies. One example of that is consent to treat. The requirement is not annual. It's good practice that you obtain that consent to treat. But if your policy says it, that's what you're going to be measured to. That's what you are held to. So I would recommend going back to your policies, looking at what boxes you have put into place that you have to fit within, and either edit the policy to expand what's allowed, such as moving to a biannual review, but keeping that annual process, so that you don't put yourself in that box, or with the consent to treat, updating it from an annual requirement to upon initial revisit or if information changes, but then holding your staff to the fire of getting that annual consent if that's your process. But your policy isn't what's driving that deficiency then, right? Because if your policy says one thing and your practice is something else, that's where deficiency comes into play. Now, this is a lot of language. I'm not going to read all of that. This is the 491.9 of what has to be captured in policy. Now, there's a lot of gray area when it comes to the law, and that's where our interpretive guidelines, our surveyor standards come in to try and help clarify how you're actually going to be measured, what questions they're actually going to ask you. This is what you are going to be held to. This you can't fight against. If there is something in this list not present within your documents, you will receive a deficiency because it's written directly in the law and you have to have it. Where we get some nuances and some gray area and some interpretive dancing, if you will, is how the surveyor is actually going to review it. What are they wanting to see in place to show that you met this requirement? And so there's some specific language that we'll get into as we go through what I call our table of contents. These are the recommended policies that we have in place and some of the elements that we want to look at to make sure are completely followed. Okay. So the table of contents, and I am not able to direct this.
Oh, I'm sorry. There we go.
We like to set up the policy to CFR. Set it up in the same direction so that when the survey comes in, it's policies and person biology. Policies on all of these that are listed. Set it up to follow the pattern of the CFR. That's how we set it up. It's just a helpful way for you to go back to that your policies to see if it makes sense. We have things that we don't have to have. We have to do not have things
Trying to find that happy medium. Okay, now try again.
Can you hear me? Is it an audio issue or is it?
It's a Zoom issue.
So in regards to the administrative policies, one of the biggest things, especially for those that are owned by a hospital system, is you have to adhere to your hospital policies, right? Your own entity as an RHC, but yet you're subject to all of the policies from your corporate, and so there's just this balance of why do I have to have two policies that say the same thing? Because I'm gonna just adhere to my hospital's policy on this anyway. Do I really have to have one for the RHC? Because that just doesn't make sense. Why would I have to maintain two policies? So there's a way you can do it. I would recommend putting in place a referral policy. Now, I'm not talking about how you're going to concentrate service. A referral that says clinic ABC owns and then will adopt the policy of hospital ABC. And what that does is it allows you to refer directly up to HR, civil rights, administrative policies, HIPAA policies, because your corporate entity already has that figured out for you. Now, if you are an independent clinic, you have to have all of these items in place. And we're gonna go into what that should look like.
All right, so we're gonna hold for just a second. We gotta try to get this fixed for our online folks. I do apologize for the folks here. We thought we were gonna tweak the volume and,
Would it be easier for me? I don't mind standing behind the podium if that's gonna be the quickest path.
it might be the quickest path to.
We can do that. Let me turn this off, just so it's not interfering.
I'm sorry.
Nope, I understand.
Yes, we have one person that says, yes, podium, please.
All right, now, I'm gonna try my best to stay still. Oh, boy. Okay, let's do this. Can you hear me? I don't feel like it's quite loud enough. Let's give it a minute. I'll just keep talking. Slightly extroverted and I have a lot of words, so we're gonna be good, okay? Are we good now?
I did get a message saying, we love you, Tressa.
Oh, thank you. Hearts. So in the administrative policies, I do recommend that referral. This is where you say Clinic ABC is owned by Hospital ABC and will adhere to all policies pertaining to HIPAA, HR, administration. Sometimes they tie in the lab if you have a lab director that outlines how you process each of the point of care tests within your clinic. But you want to make sure that you have that adoption process defined. And that negates you having to duplicate. You don't have to have an HR policy defining this in the clinic and at hospital because that's who's taking care of it for you. If you're independent, all of these need to be in place as well. Services, as Julie mentioned, you are required to list out what services are available within your clinic. We do physicals, we do ... What can you do for your patients within your physical plant? And then defining how you handle patient complaints. Sometimes this is escalated up to the hospital level because they have a system that they use for patient complaints, but it should come down to the clinic level as well. Who is their first point of contact? Where does it escalate to? And making sure that you include your surveying entity within your complaint process because that's required. How your patients need to know who they can communicate with if their complaint remains unresolved. Patient rights and responsibility, that's been in place forever. And then smoke-free environment, that's just a standard practice across the board that you define what your policy is. Again, if you look at these policies, most of them refer up. If you do have them at the clinic level as well, both of them need to be maintained and reviewed at least biannually to match your program evaluation processing. In the physical plant, this is one of those updated areas that I would mention. Some clinics put their COVID vaccine requirement under the physical plant section of their manual. Some hold it under their employee health or their HR section of their manual, but I want to make sure that we bring this across here. Even though the mandate has been updated and been removed from the law for the RHC, if your policy still says that you require vaccination of your staff for COVID-19, that's what you're going to be measured to. So either removing it completely from your policy manual, retiring the policy. If you do keep that process, that's fine. That's up to you and your administration team. But whatever your current process is, needs to match your policy, because your policy is what you're going to be held to. But moving into the rest of this section, I do want to mention the cleaning policy. There is a requirement that you keep a clean and orderly environment. Now, there's a lot of gray area within that statement itself. And Julie went into that in some detail of how that is going to be measured from a physical standpoint at survey time. But from a policy standpoint, you want to be able to cover how you sanitize and maintain a clean and orderly environment. What's required between patients visits, what's required within the exam room, if you have wheelchairs, if you have cloth chairs, if you have curtains, if you have carpet in patient care areas, how do you mitigate and remove any kind of spill? What is your process? And it needs to be defined. Exposure control, that really has not changed much in the last 20 years. This all adheres to OSHA and making sure that you have employee safety in place and that you're reporting appropriately if there's an incident. What you expect from glove use and all of that should be in place, linen handling, those types of things. Failure of essential services, this really moved more into the emergency preparedness plan. How do you handle a water outage, a power outage, or a failure of your services and utilities? What is your process? And you don't have to have it in both places as long as you reflect it somewhere, either in your policy or in your emergency preparedness plan. Hazardous materials and medical waste are usually combined into one policy. But one thing I will mention is we did have a clinic that had referred up to their hospital's waste management plan, but the language in there didn't support what the clinic was actually doing. And so the clinic needed to have its own waste management plan. How do you remove waste at your facility, and making sure that your policy matches that and that it's not just canned language from the hospital? Because how they handle waste in the OR and all of that's going to be very different than how you handle it in an outpatient facility. Pest control is a new item. Sometimes clinics tie this into their infection control plan or into their cleaning policy, but it is an update in Appendix G that you discuss how you handle and mitigate pest control issues. Typically, we see the name of the company, what their contact is, and how often they come to your facility, but it does need to be mentioned because it's directly listed in Appendix G. And then physical plant and environment, how do you maintain your space? We talk about the biomedical inspections in the preventative maintenance program that's listed here. We talk about reviewing of our equipment, such as our AED, fire extinguishers, oxygen tanks. How do you monitor your emergency equipment, your medical equipment? All of that needs to be combined into this policy. Human resources, if you are through a hospital system, this is usually an outsourced area. The clinic does not typically handle this if you have an HR department that oversees this for you. I would recommend though, because it's not the HR department that would get the deficiency if something is missing, it's the clinic. So I would recommend taking this checklist and making sure you have something that defines what the expectation is for each job type, what type of entity you are, whether it's an independent or provider-based type facility. What is your organizational structure from the medical director to administrative oversight, and what is the lines of authority within your clinic space? And then again, making sure that you define how you can get hired and fired. That's essentially what we want to have defined within the HR policies. One element I would mention is, especially if you are through one of the deeming entities or accreditors, you do need to have that standard of conduct signed and put into the HR files that this is what is expected within our clinic space. Code of conduct is another term for that sometimes. That can be tied into your staff manual if that's something that you have sign off on, or it can be specifically outlined in policy and addressed there. Now, this is where we get into the meat and potatoes of what the clinic has to have: patient care policies. One thing I will mention is in the law, the only thing that's mentioned about review of policies on a biennial basis is in regards to patient care policies. And that has to be reviewed by your medical director, one APP, and a non-staff member, AKA community member is what the term has always been. But the term directly in Appendix G is non-staff member. This can be someone from your board. This can be someone from another clinic. It does not have to be a physician level. It can be, I mean, we've signed off as non-staff members on policy manuals. It is someone who can add insight into that review, who has a professional level, and that is able to understand the intention behind those policies. But this is the only place in the law where the non-staff member is mentioned. They're not mentioned in the program evaluation. It's only mentioned in relation to policy review of patient care policies. So in relation to that policy review, you do need to have a current signature page. Now, some have gotten fancy and we have Policy Stat or some kind of online portal where we keep all of our policies. And you can see in the drop-down list who's reviewed that policy and when it was last reviewed and what their title is. And that's appropriate as long as you can show that those 3 participants are listed within that policy review. Where we come into a struggle is, especially if they are printed policies, not having a current signature approving those documents within the last 2 years can be considered a condition level deficiency because it's directly written in the law. So go back, check your manual, check your online policies, see if you can prove that all of your patient care policies have been reviewed and approved by those 3 participants. Now we're going to dive into the patient care policies. What needs to be captured here? Because I know patients present with a million things in any given week. Do we really have to have a policy for everything? That's where we get into the binders and the binders and the binders, and our office becomes a mess because we can't keep track of it all. And that's where this medical management policy becomes your best friend. As Julie mentioned earlier, most clinics use UpToDate for their outside resource if a provider needs to have a specific way to treat a patient. But it doesn't have to be a comprehensive list, because I know clinics that I walk into, provider's office, they have every book they ever paid for through medical school. You don't have to include all of that in your list. You need your main go-to approved by the medical director because they're signing off on this policy, approved resources for use for dosing and diagnosing patients. If I don't have a specific policy on what this patient presents with, where can the provider go to determine care plan? So we typically just see the language within that policy addressing these are the resources approved for use by the medical director, and then the list of resources such as UpToDate, Hippocrates, Lippincott. Those are the common ones that we see. Desk references, if it's a pediatric facility, we typically see some sort of pediatric manual. Dermatology is a common one we see. But really, what are the go-to resources? And that's always deferred to your medical director as part of their oversight of the clinic. Medications, that is a very simple term for a very complex policy. In your policy, pharmaceutical policy, drugs and biological policy, there's so many different terms. And when I do a search find on a policy engine, I come up with millions of policies, especially if you include your pharmacy department in that, right? The end goal of what you have to have in your medication policy for the RHC is what's listed in the law. And that includes administration, how you administer. Disposal is typically found missing. Recall should be covered, especially if you handle samples. And then also storage. How do you store medications within your clinic space? How do you make sure that they are safe for administration? That all needs to be encompassed in your medication policy. Also, the power outage process, especially if you handle VFCs, that's a big thing that they require. But from a policy standpoint, you need to address how you transport, how you monitor. Do you have a generator? Do you get notifications? What is your process for monitoring temps? And what is your transport? Do not take them home. Then in regards to the treatment of minors, that is very specific by state. Every state has a different law of how you are able to treat minors. Make sure that your policy matches current law. And that your policy consent to treat for minors includes the relationship to patient. Emergency care. This is one of those policies that we find missing because you have your box put together. It's kind of set to the side. We talk about poison control. We talk about all of this stuff in our policy, but it's not actually referencing the emergency kit itself. So in the relation to the emergency kit, you have to have an emergency kit in your clinic, even if you have an ER right outside your door. You have to have an emergency kit in the 4 walls of your facility. There are categories to consider, but thankfully they do defer to the medical director to determine what contents are needed based on your patient demographics and the services you offer within your clinic. And then for policy, you need to make sure that you have the contents listed, the name of the med, the quantity of the med within your emergency kit, where that kit is located in your facility, med room, lab, wherever you're keeping your kit, so that you know exactly where it's at and how to easily access it for an emergency, and who determined the contents. Typically, we see that listed to the director, medical director, but sometimes it's in coalition with other physicians or providers or based on pharmacy. Make sure that you define who determined the contents, and all that should be captured in your policy. Okay, our eyes glazed over yet? Are we still good? I'm so used to moving around and trying to capture attention. I feel like I'm a teacher knocking on a student's desk again, right? Established patient versus new patient. And this is really where we see clinics put themselves in that box. They put in their policy that they require consent upon every visit or consent annually. And then we look at their medical records and the consent is 3 years old, but they were just seen last week. And that's an automatic deficiency because you're not following your policy. So either we need to do staff education on what the requirement is, if that is what we actually want to keep in our policy, or we need to go back and edit our policy. You can always go above and beyond what your policy says, but you at least have to meet what you put in your policy. Then we move into laboratory services. Now, some of the clinics that have larger organizations, their hospital comes in and does training for their staff. They have a lab manual all on its own that says how they do competency, how they run each test, how they clean and do their controls and their logs and blah, 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 all those fun things. You can put that right into your corporate referral policy. We refer to lab manual ... and here's the person who's responsible for maintaining that. That's appropriate as long as you meet all of those requirements. But for the clinic, the RHC, you have to list what tests are available in the clinic. So you can show you're meeting that 491.9 requirement of direct services, and how you vet your staff, meaning competency, and how you handle whether you do venipuncture, all of those types of services. What do you do in your clinic space, and can you show your staff how to run each of those tests, whether it's an internal RHC policy or directly referred to lab manual that your lab director handles for you. Then we move into informed consent. There's a difference between general consent, meaning I give you permission to treat me from a legal standpoint, and informed consent, meaning this goes above and beyond primary care. This is more of an invasive type procedure. I need to know my risks before I give you consent for that specific procedure. Making sure that you have that defined in policy and you're capturing that written consent from the patient if you are doing procedures within your facility. Address it in policy, have a form, and make sure your medical records match what you've defined you're going to do. And then referral. This is outside of that corporate referral. This is talking about specialty services. Because again, we go back to the law where it says we have to prove that our patients are being seen, are being accepted outside of our clinic for services we can't offer. So referral policy, this is very important. What are your top referrals out? Are your patients being accommodated? How are you tracking and closing that loop, as Julie mentioned, of the provider order going out, that consultative appointment being scheduled? And that's not where we end it. We wait until that consultative note comes back into the medical record before we close that loop. And our policy should define that. A lot of clinics have brought in referral coordinators, and it's a great way to monitor that. I would work with them directly. How do we do this? Write it in policy so that we can hold our staff accountable to that, but also it gives them the backbone of saying, this is what you allowed me to do through policy. And it's a two-sided coin. Sterile supplies, we talked about this earlier in relation to how do I know if my provider's grabbing an instrument out of that drawer that it's sterile? And this needs to be defined in policy. What is your process? Do you send it out for sterilization to central supply? Do your staff know how to accept that instrument back, making sure it's appropriate packaging, that it's not damaged, that it's reached sterilization? Or do you use disposable only, making sure our staff know not to leave that open container because they only use the tweezers and they wanted to keep everything else from that kit in place. Once that's opened, it's gone. Or Are we doing autoclave? And I would have a very robust policy that meets directly back to the manufacturer's guidelines saying, this is how we know we reach sterilization. Here's our process, train your staff, have their acknowledgement and do competency. And then if you do cold sterilization, oh, my heartburn is already rising. Here we go. Make sure you follow exactly what that chemical says. You put it in your policy, you train on it, and you know that you're meeting all of the documentation requirements. Standard precautions, I don't think that's changed much, but I will challenge you. If you have not looked at your policy in a while because you know it hasn't changed, go back and review your standard precautions and make sure it matches correct language. One policy I reviewed said that they only did hand washing for 10 seconds. That's not appropriate anymore. That has been updated. So you knew that policy was very old. So go back and make sure that you're reviewing all of your patient care policies, all of your nursing protocols, make sure that they match current process. Incident reporting. Now, most of the time when I say this, people automatically go to OSHA employee incidents. You do need to have a policy that defines how you handle a patient incident. What is your reporting process? What happens if a wrong medication is administered? What is your process? And have that defined. Now, this section is getting ready to go under some construction. At least we've been told that for the last year or two, that there's supposed to be this big change in the law for HIPAA. We're still waiting for the final ruling because we keep getting things added in that they have to have comment periods extended. It's a mess. We were supposed to have the language back in March, then it was extended to April, then things were added and still hasn't been published. I would not do any edits to your HIPAA policies till you know what you're actually going to have to change. Don't do work that you don't have to do. Some of this may not end up in that final rule. You can start doing your legwork, of course. Some of that makes sense. It's going to go into place. Some of the biggest changes that we're seeing with HIPAA is timeline for release of records going from 30 days to 15. That's in the proposed rule. Some other things would be them having access to take pictures of their medical records and having a safe space to be able to do that. These are some of the proposed changes, but until we actually know what's going to be put in the law in regards to HIPAA, I don't think that we need to make any major changes to our policy or our practices until we know what we're actually going to be measured to. But just be aware, it's on the horizon. We're waiting for the final rule. We're being told possibly the end of the year, but that keeps getting stretched, so we'll see. At this point in time, this is typically a section we see referred up if you're under a hospital. They handle this for you. You have a compliance officer that does any breach reporting that has to take place. They define how you're securing and releasing and all of those things that you have to define in HIPAA. If you're independent, meaning you're not owned by a hospital, you do need to have a full section regarding how you secure and maintain your medical records. Now, program evaluation. This is a little bit of one of those things that we see newer clinics getting deficiencies in, because to get through your initial survey, you only have to define what you're going to do 2 years after certification and policy. So they list out directly what's in 491.11. We're going to review utilization of services. We're going to review open and closed records, and we're going to review to determine for following policies. So they put that in their policy, check mark at survey, all done. Then the surveyor comes back to do a reevaluation of their clinic, and they didn't follow what they put in policy, and they haven't done an actual program evaluation. So we're going to dive into that later this afternoon about the 491.11 and what all needs to be captured within that report. But from a policy standpoint, you do have to define what's going to be in the report, what information you're going to review, who's going to participate, and what your expectation is for timeline, annual or biannual. I would recommend putting in policy a biennial review, just so you're not putting yourself into a smaller box than you need to, but maintaining an annual review so you're capturing issues within your clinic setting on a quicker basis. From a policy standpoint, though, this is our table of contents of what we typically put in your program evaluation section, and it's who's participating. That's the advisory committee. Having a copy of your corporate compliance plan. Here's how we monitor and audit and all of those things. And then quality assessment. This is defining how we measure our clinic, what our performance improvement projects are and how we develop those, and then what is going to be reviewed within the meeting itself or within the report. I apologize. Now, civil rights is all based on OIG, and there are actually template policies directly in the platform of OIG regarding policies for civil rights. I would defer you directly to that because the language of what falls under that capture is changing on a different basis of what rights are protected under civil rights. So that would be one challenge I would give you, is go back and review your civil rights policies. Make sure that your civil rights officer, your 504 coordinator is current. Make sure that your language reflects the current list of what's protected under civil rights and that it's kept up to date. And then that you meet the requirements that you see here on the screen. Do you define non-discrimination, that you don't adhere to that? Do you have a grievance process that's separate than complaints? This is a patient who feels their rights have been infringed on. Usually complaints is regarding billing, right? Just being honest, or time of waiting at the clinic. Limited English, making sure that you have a process of how you provide services to patients who have limited English, that you have an interpreter service provider, and putting that into your policies. And then auxiliary aids, how do you handle your patients with disability? Someone who's limited sight, hearing, limited dexterity. How do you handle a patient like that? What services do you provide? And what aids can they request from your facility? And then accessibility. Do you have curb cuts into your clinic? Do you have access to all of the areas that the patients need to be? And having that defined within your clinic setting as well. Now, how many, I don't usually see radiology, but it is a growing service line within the RHC. How many have radiology in your clinic? And do you have policies directly defining radiology services in your clinic, or do you adopt hospital policy? You don't have to answer that out loud. It's just a question to think through. My main point would be to go back and look at your radiology policies and make sure that you have the things that are listed here on the screen. How do you handle a patient that refuses imaging? What is the weight limit of your machine, and have that in your policy for proper imaging? How do you handle a recall of the imaging? What is your release process if they request a release of that radiology service? How do you handle a provider order? What is your safety requirements and infection control requirements within the radiology space? What PPE do you have in place? Making sure that's defined in policy as well. And then how do you maintain the equipment? We have the preventative maintenance program we already mentioned in the physical plant section. If you tie radiology into that, you don't have to separate that out. But a lot of clinics have missed this portion in policy. We're going to dive into emergency preparedness because a lot of people kind of tie that into their policy development. We're going to tackle that in a later session. So how do we show proof of compliance? How do I answer that question in 491.11 if my clinic is following policies? We typically see that canned statement, clinic is following policy as they are currently written. That's put in the report, check, done. Or it's just not mentioned at all, and you're not adhering to all of those check marks required in 491.11. But how do we answer this question? First, doing that mock survey. Are we maintaining our facility in the way we've defined in that physical plant section? Are we doing our outdates? Are we storing our supplies appropriately? Are we monitoring our medications and handling them the way that we say we're going to do? Doing that process, and then observing your staff. If you have a policy outlining how you clean your exam rooms between each patient visit, are we observing our staff to make sure that they're adhering to that? Because that's what the surveyor is going to do. They're going to watch. They're going to be the eyes and the ears in the clinic as they're there. Not that I want to scare you. Most surveyors are very, very kind. And then do a personnel file audit. We have our HR section in policies. Our corporate policies are in place saying this is what we're going to do. Do our files match that? One of the biggest things that we find is that in policy, it says you're going to do background checks. It's not required for the RHC unless your state requires it from a licensing standpoint. But do your personnel files match the content list you put in your policy? That would be one recommendation, is going back and looking at that. And then the medical record review, which is what we're going to dive into detail now. Now, this slide gets a little convoluted because there's a lot of gray area. I even use gray on purpose. Look at that. It's the teacher spirit in me. So we have two types of chart audits that have to take place in the clinic setting: administrative and collaborative. Even in states where providers, NPs and PAs are able to act at the full scope of their licensing, if there's no oversight requirement in your state, there's still a federal oversight requirement from a chart audit standpoint. Now, the difference is if your state has a requirement, that's what you're held to. If your state does not have a requirement, then you put in your policy the number and frequency, and that's what you're measured to. Most clinics that we work with, especially in Michigan, most clinics do 10 per quarter is typically what we see. What I will say is look at your state licensing board. That's where you're going to go to know if Michigan has a requirement for percentage oversight requirement. What has to be captured in that collaborative agreement, how many providers have to participate in that collaborative agreement. It's all deferred directly to your state licensing board of what oversight is in place and has to be adhered to. If your state does not have anything, don't put more burden on your providers than you have to. The requirement base is that all APPs are covered in that review and you meet what you put in policy. So if you have an APP that's been in practice for 20 years and you have another one that's in place for a year, you might review more of this 1 year provider's records, but this one can't be forgotten just because you trust what they're doing. So making sure all APPs are included and that you meet the number and frequency you put in policy. And if you don't have a policy defining that number and frequency, it needs to be developed ASAP because that's what you're going to be held to. And then the collaborative review is always between the NDDO and the NPNPA. And it needs to cover all APPs like we just talked about. And the piece that probably gets clinics in the most trouble is this last point, which is documentation. Go back to that statement of do what you document and document what you do. If we don't have documentation to the surveyor, it didn't happen. Some clinics say, well, my EMR tracks that. We just do co-signature on the EMR. Can you pull a record of what reviews took place? Does your EMR have that capacity? Is there space for conversation between the oversight and the APP of if there were notes on that medical record that were reviewed? Can they do a telephone note or something within the record to say, this is the conversation, this is the change in care plan I would have done? So one of the tools, and I don't remember if I put it into the slideshow or not, but you can email me. My email will be at the end of the presentation. We have two tools. One is for the collaborative review and one is for the administrative review. If you don't already have a process defined, we can help you. We can make sure you have the tools and resources you need to get it accomplished. But my question really comes down to, with the collaborative review, what is your number? What is your frequency? And can you prove that you're following that? Whether it's through a report, whether it's through a signed document. Some do meeting minutes where they have a meeting every month with the providers and they document what records were reviewed, what patients, what notes were given, and both providers sign off on that. How do you prove you're meeting what you put in your policy? Any questions on collaborative before we flip the switch and go to administrative? Because this is probably what I get emailed most about. Okay, administrative. Now, how many again are under the state? This number you see defined here is what you would be held to, the 50 or 5% of that full year. So if you look at your visit count and it says you had 10,000 visits for that year, you would need to do the 50. If you had a lower visit count, you would do 5%, whichever is less, 50 or 5% is what you have to be able to show. If you're through the state. If you're through one of the accreditors, the compliance team or Quad A, you determine, like what we do with the collaborative, you determine the number and frequency, and that's what you're held to. But the compliance team does require a quarterly meeting where you review the outcomes and you document the review with your staff of the outcomes of these ongoing chart audits. Some clarify this as administrative review, some call it a quality review, some call it chart audits. There's many terms to accomplish the same thing. The intention of this is it feeds into that program evaluation. It needs to be 50 or 5%, whichever is less. And the intention of it isn't the medical decision-making like you have with the collaborative. It is, are all of the elements in 491.10 captured within this record? Did we meet the requirements listed? Do we have a consent to treat? Do we have the closed loop on labs and referrals? Did the provider sign off on the record and the timeline defined in policy? I would check that too. Did we reconcile our meds or anything that was administered during the visit? Do we have allergies listed? Do we have a treatment plan? Instructions to the patient, education. And the biggest one we find is follow-up. If the provider said 3 months, do we have a visit scheduled? Or at least a note saying patient declined because she's busy and traveling all over the United States. You know, so anyway, moving on. This needs to cover all providers. Now, I do want to clarify, peer review is not required, meaning MD to MD. Peer review is not required. The person who can do this administrative review can be you, it can be me. Someone who's trained, knows the elements, knows how to look at a record to know if it's a complete and accurate record. It does not have to be done by a physician. The collaborative does, the administrative does not. And so making sure within this record review, you have proof that you're meeting all of the required elements and that it's being done on the timeline you've defined in policy, unless you're under the state that you meet that 50 or 5%, whichever is less. And it needs to be covering all providers, including your physician levels. Now, one thing we do find, again, when we look at program evaluation meeting minutes, is they do the chart audits, but we don't know if they actually included a closed record. And I get a lot of questions about what is a closed record.
Bertha,
Yes.
before we move on, we do have one question.
Okay.
Line. We get flu and pneumonia vaccine consent for all, but have not been collecting consent for childhood immunizations. Should we?
And so there's a fine line of what's determined as an informed consent. And it's usually something that's more invasive than just the vaccinations. And Julie, do you have any insight on that piece specifically?
I don't think that that's required.
Yeah. So what Julie said, for those that are online and she wasn't able to have a microphone at this point, I took it away from her, is that it's a recommendation, not a requirement. Within your medical records themselves, when you're doing these administrative chart audits, quality chart audits, you're including a closed record. And that's defined as a deceased patient is typically what we see. Patient who's requested that you transfer out their records. Or you can define in policy what's a closed record. Maybe a patient who hasn't been to your facility in 3 years is typically what we see. But if you define that as a closed record, you can include that in your review as well. In our tool that we use, there's a right-hand column where we can put some extra notes, and we always define closed record and why it's considered closed, deceased, transferred out, something like that. So you can show documentation that a closed record was included in that review. Yes.
Wow.
So the term is, the question was just one of the closed records. The term in the regulation and the interpretive guidance is just a sample. There's not actually a determined amount of closed records that have to be reviewed as long as it's included. We typically recommend 15 records per quarter. So you do 10 records of the collaborative, the medical director or whoever the designated physician is, does the review, they sign off on that, the APP acknowledges all of that, 10 records. Take those same 10 records, add in a couple of physician records, add in a closed record, and do the 15 a quarter of the administrative review. And you can use the same records, kind of kill two birds with one stone, if you will. Some clinics also use the administrative review to drive their quality measures. So they pick a specific diagnosis that they're working towards, such as diabetic care, making sure that the A1Cs are being brought into compliance. And so that's the type of records that they're pulling for this type of review, so that they can, again, use it for their advantage. You have to do the review anyway. Why not make it work for you? Just a recommendation. You don't have to. The end goal is you meet your policy for both the collaborative and the administrative for the number and frequency. Any questions on this piece? Because this is a lot.
Can you just speak a little bit on the administrative chart audit as to the requirement for communicating back to the providers on a quarterly basis?
I'm not sure. I'm not understanding.
Is that a requirement? So after the chart audit is done,
Mhm.
what is required formally or informally?
On the administrative review, where you're looking to see if the elements are present, there's not a requirement unless you're through the compliance team where you're reviewing the outcomes of the administrative review. But if you're under the state, there's not a requirement that that feedback get back to your staff. However, it is good practice So if you are seeing a repeat issue, having those educational conversations, those, I like to look at them as opportunities for education. If you have those conversations with your providers about here's a repeat issue that we're seeing within our medical records, this could cause us a deficiency at time of survey, and then monitoring that through this ongoing audit. I don't know why you would do the work and not take it back to your staff. That to me means you're just doing work just to do work. And it really does become a benefit. If you see missing consent to treat, that's a great opportunity to take that report to your receptionist and use that as a training model. If you're seeing where providers are not closing it in the timeline you've defined, that's a great opportunity to take it back to them one-on-one and address, here's the issue, here's what we're seeing. We just want to make sure that you have legal records that are complete so that you're supported as well. And then, but it's a whole team effort. And this audit really becomes a way for you to see where are the gaps. I like to look at it as a preventative care for your clinic, right? You're able to do that in-depth review of saying, are we doing the best care for our patients? Are we documenting the work that our staff are doing? And are we meeting the requirements that are in 49110? Because we know the measurement is coming. We know the survey is going to come and they're going to see what we hope we find ourselves. That's what I tell clinics all the time when I go in. You want me to find the issue so the surveyor doesn't. And that's exactly what this chart audit is meant to do. It gives you the opportunity to see what are the issues, what are those things that we're missing. We have constant turnover in staff. Are we doing our training properly? Are there opportunities for us to improve? And having those conversations to improve our business moving forward.
Like Chris said, the results of it feed up into that program eval. And the program eval is given to a medical record at least the results. With the compliance team, and I think good practice, they want you to feed it into a quarterly, and the results of the quarterly feed up to the program eval. And that's probably how that communication happens.
Do you want to repeat or do you want me to? All right. So what Julie shared is, and she said it so much better than I will, but basically the intention behind that is, you go ahead because I'm not gonna be able to summarize it like you did.
These chart audits feed up into the biennial program evaluation, which again, you recommend. And if you're with the compliance team, which is best practice and the best practice, you are required under the compliance team. They want you to take the results of that into a quarterly quality meeting, which again, I think is just a good idea. And then the results of the quarterly meetings will feed up into the program eval, which eventually, at least your medical director and one of your APPs is going to see.
And then one of the things that I get, most of you have emailed me and said, can you just please send me language that shows that you have to do this because I'm not getting any support. And so one of the things I commonly do is I email language out to managers from Appendix G, from your surveying entities, standards and requirements to help support these things that we're telling you you have to do. Because you need a backbone to be able to take back and say, no, this actually has to be done. And so that's why I wanted to include the next few slides, is this is language directly from Appendix G that you can use to help support as you develop your chart audit process, if this is something that's currently out of compliance. Tressa?
Yes.
One
One more question from the chat. If the training today shows that you are deficient in a few areas, is it too late to fix the issues starting tomorrow? If you make the changes and is audited in 2 months or more, will you be considered deficient or compliant by the reviewer?
And this is where that conversation of doing a self report becomes very helpful, because you don't know what you don't know until it comes to the forefront of your mind. How do you hold it accountable, right? And so once these areas of deficiency become apparent, that's when you set your plan of correction, internal report, and you only show it to the surveyor if they ask for it, because you don't want to raise a red flag for yourself that you don't need. Most of the time though, if you're doing these ongoing audits and you're able to see that projection of growth through improvement in these quarterly audits or in these administrative audits, You're capturing the issue before the surveyor would ever see it. And normally what we see when a surveyor comes into their facility, into your facility, is they usually go back maybe 2 weeks, maybe 4 weeks. Sometimes they will ask to go back further in your scheduling system, but that's normally what they do because they need to have space and time to follow those loops from a lab order and a consultative order, from the initial visit, following that communication through to show if you're doing follow-up appropriately within your facility.
One more comment.
Yes.
Since the ultimate goal here is to get up to that program evaluation, and if you haven't done anything, you at least want to go back to the last program eval.
Mhm.
And make sure that you have the chart audits done that will feed into your next program evaluation. So if you're due for a program evaluation in December, but you haven't done any chart audits in years, at least do the 50 or 5% for the 2 years that are going to be captured in that next meeting.
Yep.
So that you have a complete meeting, so you have complete record for the next meeting that you're having.
Yes, agreed. Thank you, Julie. So this language here, I even gave a page number so you can go back and read the context around it as well, just because I'm that kind of person. I like to know the why behind the language. And so I just want to make that there in case you're like me. But this is where it specifically says that in states where state law does requires a collaborative review, that's what you're held to. And then where co-signature is not required, the RHC regulation still requires periodic physician review of the clinical records of patients cared for by non-physician practitioners. So this is where it's showing you that collaborative review is required, even if you're a full scope state. Now, this statement is where I like it because this gives you some space. There's not a particular time frame to satisfy this requirement. That's specifically in Appendix G. This is where you get to determine the number and frequency, put it in your policy, and that's what you're held to. I did include the tool. Look at that. I feel prepared. So this is the collaborative tool that we have given to clinics on a continuous basis, and it has helped them be successful in showing proof that they're documenting what they're doing. And this is where they're able to list out the records that are being reviewed. There's space for the APP to be able to respond to any notes that were given, and they both sign it. And this is what you keep for quarterly proof that you're doing what you said you were going to do. 49110 is your guideline. This is your law of what has to be captured in the patient record. Social data is really rising up in awareness within medical record reviews of what has to be captured. Identification, social data, evidence of consent, pertinent medical history, assessment of health status, healthcare needs of the patient, and a brief summary of the episode disposition and instructions to the patient. Normally, the piece we find missing from this specific paragraph is the social data. Consent to treats are either incomplete or missing altogether, or they're waiting in the scan pile. And the instructions to the patient are just not present. What I really love, the type A personality in me, is when I see the diagnosis and then there's a care plan for each diagnosis. That just makes my heart happy because I know that patient is leaving knowing exactly what their next step in care plan is. They know when their next appointment is. They know what the instructions are for that new medication they just started. They know what to look for adverse effects if they have any issues with that new med. They leave knowing what their next lab is. They leave knowing exactly what's expected of them as the patient. One thing I will note, you are not responsible for babysitting your patients. Okay? You are responsible to document your due diligence. That you have telephone notes of communications you've had, that you follow up with them if they miss their appointment, that you have documentation on your end, because we all know patients can be non-compliant, right? We all have that experience, but you are just documenting your due diligence within that.
Real quick,
Yes.
Tressa, for those of you who are staying tomorrow, one of our presentations is on social drivers of health. And as Tressa mentioned, it is becoming more and more relevant. And our federal partners are really looking at this and health equity. So if you're not signed up, there's a link. I've sent out several emails. You can sign up virtually. or you can stay over tomorrow and join us for that. So it's going to be a great presentation.
Thank you, Jill. Other elements that have to be included in your medical records are your physical exam. Now that has lightened up, making sure that you at least review the systems that relate back to the main reason for visit. Diagnostic and laboratory test results, especially if you're doing them in-house, that it's brought into that medical record. And then consultative findings. And this is where those loops really become apparent. Do you have a tracking system in place? Are you relying on your medical record? And is your medical record system robust enough to track referrals out, lab services being ordered out until you get that result back and it's being sent to your patient, especially for abnormal results? And then for the consultative services, all the way from the provider order to that consultative note coming back into the record. Do we know if our patients have been seen? Or are we just waiting until they have a medication refill to touch base with that patient again? That's where we don't want to get to. We want to make sure that our patients are adhering to the care plan we've given them. Again, you don't have to babysit, but you do need to document that you are doing your due diligence to follow them from the appointment until they come back. All physicians' orders, reportments of treatments and medications and other pertinent information, they really like that term, necessary to monitor the patient's progress. And then signature. This is where we find things missing sometimes, where the record is 3 weeks old and it's still not closed. Ooh. And then if it starts impacting your billing ability, oh boy, that's where I would be using these chart audits to have conversations, because it really does impact not just you, not just the clinic's bottom line, but the patient as well. This is where we get into the administrative. This is your backbone for the administrative review. What's required? And this is on page 87, Appendix G. And this is where it covers that number, the 50 or 5%. But this is if your state, the accrediting organizations have allowed you to determine number and frequency for the administrative as well. And then the evaluation where followed may be conducted by a physician. That is allowable because they are able to see the oversight of the record. But this is where we get that allowance to have someone else do that administrative review, a non-physician practitioner, an RN, or other. There's a lot of space within that word other. Personnel who meet the RHC's qualifications criteria. Sometimes you get a surveyor with a bee in their bonnet. And I just quoted my mother, but I love her, it's okay. And they have an idea that this is what you have to do. If you put it in policy, what qualifies someone to be able to do your administrative review, that gives you a lot of backbone. You don't have to, it's a recommendation. And this is the tool that we utilize for administrative reviews. And it lists out all of those components that are in 491-10, and it gives you space to be able to meet. In that right-hand column is where we define this is the closed record that we included in this audit. And it gives you space to do that. Are the elements present? Is everything that's in 491-10 being captured in our legal records? We were brought to court for that visit. Do we have something to stand on? So if you want to utilize this tool, please email me. I can send you the Word version and you can make it your own version. We want you to have resources. We want you to have the tools to carry out your position. If you are through one of the accreditors, I would recommend using their tool because they have a tool already developed and you want to measure yourself the same way they are. Now this mimics both of them, but I'm a visual person. Who else is a visual person? I'm a visual learner. So if I see their tool and I see one word might be a little bit different, it causes me some anxiety. So use the test that you're going to take, right? That's what this is meant to be. It's supposed to be an open book test. Your survey is. You have been given the regulations, you've been given the interpretive guidelines. If you're through an accreditor, they have the standards and they just go through with their checklist. It's supposed to be an open book test. But there's a lot of things you're being tested on. And so hopefully this helps you to put a practice into place and to streamline it. But use this tool if it's helpful to you. So how do we streamline things? What are some ways that you can go back and clean up your policy manual, remove some of that burden that doesn't need to be in place? How do we streamline things? Do a crosswalk. Take the regulations, take this tool if you need to, the table of contents that I gave you, go back to your policy manual and do a crosswalk. What do I have in place? What policy number matches that requirement? and do a crosswalk so you can say, oh, they want to see my drugs and biological policy, here's the policy number, and it just gives you that direct link. That has been helpful to me. And then do that referral process. Make sure you have that adoption policy saying, we're going to adhere to policies, ... Now, one thing I do find missing, especially if you have policy stat or something like that, is what policies relate to the RHC. Sometimes it's just an organization-wide policy, but what policies are held at the RHC level? Do we have the department defined? And is it easy to navigate? Can I quickly find the keywords that the surveyor needs to look at? I would put together a table of contents and where it can be found, whether it's in a printed binder or an online policy manual.
Question online, should we keep records of the audits in our printed operations manual or electronic records of the audits sufficient?
As long as you can access it as time of survey, whatever's going to work best for you, but access is the key. Sometimes their systems go down, just so you know. Policies can be online. Most clinics have moved to that process. Emergency plan does have to be printed. Policies can be online, but you need to make sure you can access them if your system is down that day. And then from there, retire outdated policies. This is really where that referral to really helps, because you don't have to monitor when the hospital changes their policy also. You're just going to adhere directly to it. Remove things that are no longer applicable to you. Maybe you switched out a device you were using and that policy no longer matches what you're doing. Get that policy out of that binder. It's too much. And then make sure your staff know where they can find your policies, that they understand your policies. And the easiest way to do that is through an acknowledgement form. Have them review them and acknowledge that they've reviewed your policies. Yes.
Expired policies for any amount of time or trash or whatever.
Typical, what we recommend is that you keep it from previous survey to next survey, but you can have them scanned into a computer and just have it available in case they're asked for. But you need to at least have your current version of policy available with current signatures from your medical director, APP, and non-staff member available at time of survey. But we typically recommend, same with your chart audits, same with your policy retirement, anything that the surveyor could ask for, we recommend keeping from last survey to next. Some of you though, it's been 20 years since your last survey. I've had a couple of clinics that have had a long duration between surveys. That's a long time to keep documentation. Most of the accreditors are on a 3-year cycle of rotation for surveys, and that's very helpful because you know your timeline. Most states now though, especially Michigan, we've seen them move to a 5 to 7 year timeline. And you're maintaining your medical records for at least 6 years. And so we would follow that same time. Thank you. And then approval. I know I've beaten this to death at this point, but please, please, please go back and check and see when your last date of approval was for your policies. It has to be within the last 2 years. Make sure your policy that says you're going to review your policies is current and says biennial, because that's another one. And that you haven't put yourself in a box you don't need to be in. Then set yourself reminders. Now I have my phone here and I have a Google Calendar, and I was talking with someone earlier that if it doesn't go in my calendar, it doesn't happen because I don't know where I'm at on a day-to-day, right? So set yourself a reminder. When is your next policy review due? When is your next program evaluation meeting due? When is your next chart audit due? And set yourself your reminders, whether it's an electronic platform, whether you have a color-coded planner like my mother does, whatever works best for you. Develop a system and track it. Assign policies for review. Now this, I actually had a clinic that they had policy stat. They sent their policies off to the medical director first, then to the APP, then to the community member, and then they sent it to the charge nurse, and then they sent it to the staff, and then they sent it to all of these people. And the last signature on that policy manual was 3 months after the medical director reviewed that policy. So really the 3 required signatures, you want to make sure that those are, that's your timeline, that's your driver of when the next review is due. Because sometimes it sets the automatic based on who last reviewed that policy, but it might not be a requirement of that person reviewing them. And then I would recommend keeping a summary of changes, because sometimes it's mid-year. Sometimes it's, if you're doing a biennial review, it's halfway through that first year that you're making a policy change, but you're not capturing it in your until that following year. So I would recommend keeping a summary of changes. What policies are you retiring? What policies are you editing? What services are you added to your clinic? So therefore you had to have a new policy, and keeping a summary of the changes that you're making so that you don't have to think back for 2 years and you're prepared for your program evaluation. Any questions?
Did I take that one? Oh, there is one more on my screen.
I think I heard you say policies are to be reviewed every 2 years. What did you recommend that we review biannually? Biannually, every 2 years, all patient care policies have to be reviewed, and you need a signature page from your medical director, APP, and non-staff member. Most clinics do an annual review process. And they send it through an advisory board, but the requirement is all patient care policies have to be reviewed by those 3 required participants on an every 2-year basis. I hope that answered it. Other questions? I do have my email here. If you want to email me directly regarding those forms that you saw in the slide presentation, I'd be happy to send those to you as well.